Hi, this is Brian Kim. I'm going to share with you case number 213 in the Best Way to Do Cataract Surgery series. This is an intumescent white cataract, not a terribly intumescent lens, but it is a little bit intumescent. You're going to see Trypan blue placement, as well as my two-handed capsulorhexis technique to help me in case I start to lose control of the rhexis. And then you're going to see terminal chop, cross chop, and how I'm able to systematically and easily disassemble the lens utilizing less ultrasonic energy and vacuum, and hopefully achieve clearer corneas post-op day one. So you can see this is the lens. It's a rather dense lens, also a white lens. And you can see there's some convexity to the anterior capsule, suggesting an intumescent lens. I use a corneal marker, which will help me to center and size the rhexis. I make my paracentesis incision first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some intracameral air. And you can see something interesting. I'm going to try to put the Trypan blue in the right side incision and then the left side incision. So again, through the right side incision, you can see I'm able to maintain that bubble, and I'm pushing the dye and painting the anterior capsule. But as I go through the left side incision, suddenly the entire bubble collapses. And so it's rather interesting. It just goes to show both incisions are a little bit different. And what I think is going on is my left side incision is a little bit longer, and it's contacting that air bubble before the right side incision. And so that's why I'm able to maintain the air bubble through the right side incision as I'm painting the anterior capsule with the dye. But on the left side, as soon as I went in, all the air came out. And so it's interesting how incisional architecture can affect the ability for that air bubble to stay in the anterior chamber. So I go ahead and inject some dispersive viscoelastic to remove the dye in the bubble, but you can see the bubble doesn't even come out, which is, again, rather interesting. That right side incision architecture was such that it didn't encourage that bubble to come out. And so this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. So I use these Moria micro-Rhexis forceps. I'm going to puncture the center. And I puncture the center, and then I'm watching. And you can see there's some milk coming out. Not a whole lot, there's some. So then I'm using the dispersive viscoelastic to tamponade the capsule down, the peripheral capsule. And I know this, as long as it didn't radialize, all I have to do is make sure I push down the capsule with the viscoelastic, and then making sure I don't make the rhexis too large. Because if you go too far peripheral, it's going to start going downhill, and it's going to be really strong radialization forces. So you want to make sure you don't go too far peripheral. Just stay right on that edge. I'm pushing some more viscoelastic on the periphery of the anterior capsule, trying to keep it down. And you can see I'm using a two-handed maneuver, making the rhexis, but also pushing more viscoelastic with the dispersive viscoelastic cannula simultaneously. And so you see I'm trying to very carefully go around, pushing that viscoelastic as I go, trying to achieve and maintain a well-centered and sized rhexis, and then that's the finishing of the rhexis. Then I'm going to go in with the capsulorhexis hydrodissection technique. I place the cannula under the rhexis edge contra-incisionally, point the tip down. Of course, you can't see a wave, but you saw the lens start to elevate, decompress, and the lens begins to spin. Again, in my experience, these white lenses tend to be fairly disassociated from the capsule bag, and the lens begins to spin rather easily on a consistent basis. Removing the surface epinuclear material, and this is the terminal chop. I'm going to start to sculpt a central groove. Again, I stay within the diameter of the rhexis. When I do this, I just want to debulk the central core. Again, by debulking the central core, you'll be able to achieve a more consistent fracturing of the lens in half without encountering that posterior plate phenomenon. And what I do is I go ahead and place the chopper around the Rhexis edge, contra-incisionally, fracturing from the terminal side. And as you separate the lens pieces, that fracture point propagates all the way through and through like dominoes. Placing the chopper around the right heminucleus, pulling it centrally toward the phaco tip and fracturing that right heminucleus in half. Placing the chopper around that first quadrant, performing the same cross-chop maneuver. It's a little bit stuck. I have to lift that piece up. It's having a little bit of trouble coming up with the chopper, and then I'm using a little bit of vacuum to lift it, and finally it comes up. So sometimes if you have to use a little bit of vacuum, that's fine too, but you saw how I tried to at least pull the piece up with the chopper. Always the safest bet in these situations. Crushing the lens into smaller pieces and then emulsifying the lens piece. Separating the second quadrant from the rest of the lens, getting around it with the chopper and crushing it in half. Again, that is another cross-chop maneuver. Lifting that fragment up with some vacuum and then crushing it between the instruments and then emulsifying the lens piece. Loosening that fragment up, lifting it up with some vacuum and then crushing it between the instruments and then emulsifying the lens piece. Turning the second heminucleus in front of me, placing the chopper around the lens, hooking the peripheral lens, placing the phaco tip deep in the bag, and then using that mechanical force, another cross-chop maneuver, to bisect that lens, doing the same maneuver around that third quadrant, bisecting the lens. Again, pure mechanical fracturing forces, no use of ultrasonic energy or vacuum when I'm bisecting the lens piece. I'm just maintaining infusion. That's it. By utilizing the instruments to crush the lens, you have exquisite control. You don't have to worry about post-occlusion surge. You don't have to worry about accidentally having corneal wound burn. When you're driving the lens disassembly with ultrasonic energy and vacuum and having to grab pieces with vacuum to hold the lens pieces, to chop it, to try to emulsify these large chunks of pieces, that's when you get into trouble. So when you leverage mechanical forces, you can very carefully, just under irrigation only, just position the instruments around the lens pieces, crush the lens, and keep doing this until the pieces are smaller and smaller, and then eat up the pieces once the pieces are smaller. Once the pieces are smaller, the chances of corneal wound burn are much less because you're not going to get terrible occlusion of the tip. And then also your chances of post-occlusion surge are less because, again, same phenomenon. You're not going to have these large chunks that are occluding the tip. And then when you have sudden loss of resistance, you have chamber collapse. You just bypass all of those issues by going and doing this type of surgery. Again, leveraging mechanical fracturing forces to disassemble the lens. So this is the last piece. You can see there's no cortex, there's no epinucleus, there's nothing to protect you. So I'm very carefully using mechanical forces to crush the lens into smaller pieces and then placing that chopper deep to protect the posterior capsule. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece, removing the cortical material from anterior to posterior. Again, because this bag is relatively empty of lens material, it also means it's not going to peel systematically versus if you had a nice shell of cortex or thin layer of epinucleus, you can peel from anterior to posterior like peeling banana. But in this case, you don't have that, so you'll have to just very carefully grab those random fibers and then switch to polish mode, polishing underneath the Rhexis edge and into the capsule fornix a little bit deeper, so you can more safely polish without accidentally grabbing the capsule and causing zonular stress. That's why I love the polymer tip and the polish mode. And as you see on every case, I spent a lot of time polishing because you got to get all that stuff out of the bag. Switching to Cortex mode and then pulsing into the subincisional capsule fornix, you can see there's a bunch of stuff that flies out. And again, unless you look, you can't find it. Again, and as I've said, you can use bimanual, but with bimanual, you have metal tips. And metal tips, there's always a risk that you can tear the capsule. With the polymer tip, that rarely happens. And so that's why I like to pulse with the BSS into the subincisional fornix, and I'm able to get that stuff out. And then you can see I'm using the sweeping and removing and peeling off some of that stubborn stuff into the subincisional fornix. And that secondary maneuver, first pulsing and then sweeping, really gives me a lot of confidence that I'm cleaning the bag completely. Remember that subincisional area is the hardest part to ensure because remember, in front of you, you can use the INA to grab stuff, but right underneath you, it's a little bit more of a challenge. Because this is a dense lens with an intumescent lens, I prefer a three-piece lens always in these cases. I always worry about zonulopathy, so I widen the incision, and this is a three-piece lens. I'm going to inject it into the capsular bag. Turn the bevel to the left. As the leading haptic comes out, I want to make sure it's flat. But before I do that, I push some more cohesive viscoelastic to fill the bag because as I tried to push the lens in, there was some OVD that came out. Fill the bag up again, making sure the leading haptic goes into the bag, rotating my hand so the optic comes out flat, have the trailing haptic come out of the eye, dialing the trailing haptic into the bag with the Maltzman. Going in with irrigation off, activating irrigation, getting underneath the lens quickly, removing all the viscoelastic from within the bag, repositing the optic back down, switching to polish mode, polishing underneath the Rhexis edge, removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a fairly dense lens, a white intumescent lens. I didn't feel like it was terribly intumescent, so that's why you saw I used the Moria Micro Rhexis forceps. I just punctured the center. I saw a little bit of milk coming out, and then I used the dispersive viscoelastic cannula to push down on the capsule. Again, I was pushing down on the peripheral capsule, making sure as I did the Rhexis, I didn't go too far peripheral, because I knew that the architecture of the anterior capsule was rather convex, and so if I go too far peripheral, I'll have significant radialization forces. I made sure I didn't accidentally make the Rhexis too big, which would have started to run out. And again, I used the viscoelastic cannula to help me control the Rhexis. You saw again terminal chop to minimize the risk of having a posterior plate phenomenon, careful lens disassembly. And despite this dense lens, this patient had a clear cornea post-op day 1, and the patient was happy with the vision. So I hope this was helpful to you, and I thank you for your attention.